Well, welcome everyone. It is 12 o'clock, and to respect everyone's time, we'll go ahead and get started. We'll just go over a few hygiene issues first regarding muting your microphone, unless you are speaking, of course, or have a question. Please silence any phones that you have, turn off your pagers, close doors, and try to minimize any other distractions that might come across our audio or video line. And we will be asking a few questions, and we'd love if people can participate and respond to the questions. And the way to do that is to go on any web browser to rwpoll.com and enter the session ID UW Echo, all one word, lowercase. So that will get you into our question and answer response system. We will just go around the table here quickly and introduce ourselves, and then allow any people joining to also introduce themselves, especially new people. So maybe we could start here.
I'm Sharon White with Palliative Care.
My name's Greg. I'm one of the cardiology pharmacists.
Kevin O'Brien. I'm one of the heart failure cardiologists.
Todd Dardis, heart failure cardiologist.
Jason Tran, social work.
Carrie Boom, nurse practitioner with the cardiology ICU.
Great, and maybe Lori and Dr. Burnside, or I'm sorry, Laura.
Yep, absolutely. Hi, my name is Laura Satina. I'm a clinical account manager for the U system representing Providence Senior and Community Services, which hospice is one of our service lines.
And I'm Lee Burnside. I am a palliative care doc at Harborview and am one of the medical directors at Providence Hospice.
Great, thanks for joining today.
Thank you for having us.
Okay, with that, we will go ahead and get started with our didactic. So please do log into rwpoll.com. And I'll introduce Dr. Kevin O'Brien, who's giving our topic today, putting it all together, pharmacology.
Okay, great. Thanks, Todd. And here are my disclosures. Okay, what do we do?
Versus in relation to the left. Give it a little click right there. There you go. You got it.
Got it? Okay. So we must have got
An intermittent connection.
Yeah. Oh, okay. So the objectives for today are this talk is really sort of a summary of the talks we've had to date on different pharmacologic means of treating heart failure. And at the end of this, we'll hope you understand the role of sacubitril, valsartan, or Entresto in treating heart failure with reduced ejection fraction based on new guideline recommendations, and then integrating the lectures so far, planned dose initiation and dose titration for beta blockers, ACE inhibitors or ARBs, spironolactone and or the Entresto, and then address issues of polypharmacy and cost with patients. So 3 questions. The first is, a 59-year-old man follows up in your clinic after an index myocardial infarction. During his hospitalization, he had a stent placed in the mid-LAD. His ejection fraction was measured at 28%, and his creatinine was 2.4 that admission. He was sent home with prescriptions for aspirin, clopidogrel, simvastatin, and long-acting metoprolol. And in your office, his creatinine is 1.3. So the medication most likely to reduce long-term mortality is A, atenolol, B, diltiazem, C, omega-3 fatty acids, D, ramipril, and E, warfarin. And if you have been following along with the previous talks, the 3 questions are all taken from previous talks. So, okay.
So go ahead and enter your response on Poll Everywhere. All right, so we've got 4 responses. Let's go ahead and take a look here.
Okay, so we'll go through this. We'll go through this at the end. Number 2, a 65-year-old man follows up in your clinic after a heart attack. During his hospitalization, he had a stent placed in the LAD. His ejection fraction was measured at 38%. Sent home with prescriptions for aspirin, clopidogrel, and atorvastatin. In your office, his blood pressure is 94/68. The first medication to initiate is A, atenolol, B, long-acting metoprolol, C, lisinopril, D, carvedilol, or E, digoxin. Polls open.
All right.
All righty. Okay, so the choice is between lisinopril and carvedilol. So this is an important kind of sequencing question that we'll address in the talk. Okay, the third question is, a 73-year-old man with a history of ischemic cardiomyopathy presents to established care after moving. He had a myocardial infarction in 2003 and an ejection fraction of 23% measured 2 months prior to the visit today. He's taking aspirin, lisinopril 15 milligrams daily, metoprolol succinate 75 milligrams twice daily, and simvastatin. His creatinine's 1.6 and his estimated glomerular filtration rate is low at 39. His potassium is 3.8. He has no medication allergies. You discussed the case with a medical student, explain A, increasing the statin dose is more likely to reduce mortality than spironolactone. B, maximum spironolactone for his renal function is 12.5 milligrams daily. C is maximum spironolactone for his renal function is 25 milligrams daily. Or D, spironolactone is not indicated given his age.
All right. There we go. Got our fun.
Okay.
Don't touch it. There we go.
So the majority went for spironolactone at a reduced dose of 12.5 milligrams daily. Good, good. Okay. So the first thing we're going to do is review the key take-home points from the diuretic usage talk. And that is focusing on outpatient diuretic therapy. First, in most systolic heart failure patients, their optimal volume status is determined by their JVP. We're using that as a surrogate for the central venous pressure. And if we can see their next veins, we can use JVP with caveat that if that assumes that patients have at most mild TR. If they have more TR, moderate or severe, then we'll tend to overestimate the CVP using the jugular venous pressure. Then the second point is their weight at their optimal JVP or CVP is considered their dry weight. And once we've established that, then we can follow daily weights to detect early volume increase and try to avoid admission by up-titrating diuretics until they get back down to their previously established dry weight. And then I couldn't help myself to still include this point that weight change is a better indicator of progress in hospitalized patients than net intake and output. We tend to always overestimate how well we're doing if we look at net INO. So following weights in the hospital and at home is probably the best way to assess where people are in terms of their volume status. And then just to remind you that if the equivalent doses of the 3 commonly used loop diuretics are furosemide 40 milligrams, about equal to torsemide 20 milligrams, is about equal to bumetanide 1 milligram. So we use that a lot, both in the outpatient and the inpatient setting if we're trying to switch diuretics. Then a couple of slides of take-home points from Todd's nice ACE inhibitor angiotensin receptor blocker talk. He posed 4 clinical conundrums. So the first one was, should doses be escalated in patients, or should you just put them on a low dose of ACE inhibitor call it good? And the answer to that is yes, we should try to up-titrate doses. Based on the Atlas trial, there was a 9 to 15% decrease in endpoint, the cardiovascular specific endpoints with a higher dose of lisinopril than with a lower dose. And then in terms of how often dose should be escalated, it should be about every 2 weeks. So if we look at the flow diagram, we'll start and increase the dose. You start at a minimum dose, increase slowly, warn patients, particularly with the ACE inhibitors, of risk of cough or angioedema. And you might want to consider that alternating up titration of beta blocker and ACE inhibitors on separate visits. In fact, in reality, often if patients have good blood pressure, we'll do them both on the same visit. Then how often should you check up on them? Every 2 weeks, and that's because the majority of changes in potassium or creatinine occur within 2 weeks. And the key parameters to look for is that you want the absolute creatinine to be less than 3. Overall, we could expect a creatinine increase of up to 30%, but a creatinine increase above that amount means that they can't tolerate that higher dose of ACE inhibitor or ARB. And we want to make sure that the potassium remains at 5 or less to avoid risk to minimize risk of subsequent hyperkalemia. And then the particular symptoms that you want to assess at every 2 weeks are fatigue. Another one is orthostasis. If somebody's orthostatic, that may be a sign that they're over-diuresed. And as you're able to get people on more vasodilator, their cardiac output can improve and renal blood delivery can improve. So they can actually often require a down titration in diuretic doses you've gone up on ACE or ARB. And we're aiming for a systolic blood pressure above 90, probably in the 90 to 100 millimeters of mercury range. Second set of take points are what about these important side effects of cough and angioedema with the ACE inhibitors? Maybe 5 to 25% have a cough. In that case, that's a reasonable situation which you could consider just switching them from an ACE inhibitor to an angiotensin receptor blocker. Don't replace them with another ACE. If they're having a cough, ACE-related cough with one agent, they're going to have it with any of the others. But also importantly, the cough can persist for up to 3 months after you've switched from an ACE to an ARB. Fortunately, the risk of angioedema is quite rare, but of course, if patients have any symptoms of that, they should stop the medication immediately and consider emergency medical help. With regard to whether ACE inhibitors or ARBs should be used together, in general, the answer is no. We switch to an ARB if patients of ACE inhibitors is not tolerated. And the ACE inhibitor ARB combination, when it's been studied in large trials, showed no benefit of the combination, and in fact, an increased risk for harm due to, in particular, worsening renal function and hyperkalemia. Okay, beta blockers. Key points from Dr. Marr's talk on beta blockers. The first is that they're not immediately beneficial. They can improve ejection fraction in contradistinction to the ACEs and ARBs, which don't improve ejection fraction. But the ejection fraction change and the benefit, therefore, can take up to several months. So because they're not immediately beneficial, the addition of beta blockers should follow ACE inhibitor or ARB initiation. Then to try to titrate to the highest dose tolerated, a couple of key parameter that we often follow in clinic is that we're aiming for a resting heart rate in the low 60s. And again, consider alternating up titration of ACE inhibitor and beta blockers at separate clinic visits. Though again, if patients have blood pressure, have a reasonable amount of blood pressure, you could consider going up on them together. And unfortunately, if somebody is intolerant to beta blockers, that's a very poor prognostic sign, and that, among other things, that should definitely trigger consideration of referral for advanced heart failure therapies. And then finally, the question of digoxin often comes up, and I think suffice it to say that the The study that was done that showed a benefit of DIG in decreasing hospitalizations was really done in the pre-beta blocker era. So we don't have contemporary evidence that adding digoxin to ACE inhibitor and beta blockers is beneficial. And some authorities are concerned about harm with adding that. What about mineralocorticoid receptor antagonists? The benefit of MRAs and heart failure therapy has been studied on the background of ACE inhibitors or ARBs plus beta blockers. And it's been demonstrated, they've been demonstrated to be of benefit in people with class 2 through 4 heart failure and post-MI patients with an EF less than 40%. And importantly, the magnitude of reductions in mortality and heart failure hospitalizations are similar with MRAs to those seen with vasodilators like ACE inhibitors, ARBs, or beta blockers. Important points to remember in terms of use are that there are some guideline recommended steps to limit potential MRA toxicity. One of the key ones is you don't want to use them, add them onto an ACE or ARB combination. Actually, this is another reason why I don't think, in general, we hardly ever would use ACE inhibitors and ARBs together, because we want to be able to get patients, if possible, on MRAs as well. Because you consider stopping potassium supplements, remember close monitoring, and then start with a low initial dose, and particularly dose reduce if the patients have renal dysfunction. So the table on the bottom would have been useful in trying to decide on that third question, what dose to use of these agents. Another thing, I think, another point to remember, eplerenone is about half as potent on a milligram basis as spironolactone. So the relative dose of eplerenone is twice that of the corresponding dose of spironolactone. And we tend to just start with spironolactone. And so to put these sets of therapies together, we kind of approach this in a stepwise fashion. The first thing is if somebody presents with decompensated heart failure, you have to start with decongestion, diuretics. Next, if they have adequate blood pressure, to start vasodilators, and ACE inhibitors are preferred. If they're intolerant to ACE inhibitors, ARBs have shown a similar effect in reducing mortality. And then if patients are intolerant of ACE inhibitors or ARBs, then the preferred combination is hydralazine and nitrates. But like beta blocker intolerance, if somebody's intolerant to ACE inhibitors or ARB, that's also a very poor prognostic sign. Then once you've gotten fluid off, have a patient close to their dry weight and on some vasodilators, if their blood pressure would tolerate it, you could then start beta blockers. And then finally, MRAs are preferred because they do have a dramatic influence on mortality. But you have to take into account the patient's risk for hyperkalemia and their degree of renal dysfunction when making that decision. And then finally, digoxin's benefit is unclear in the modern era. And then some rule of thumb guidelines for targeting each of these therapies are that we want to decongest first, try to get people to their dry or baseline weight. Then add vasodilators, potentially trying to achieve a systolic blood pressure of 90 or greater. And then start some beta blocker with the ultimate goal of a target heart rate in the low 60s. And the last pharmacologic thing I wanted to talk about was the sacubitril angiotensin receptor blocker combination that's marketed under the trade name Entresto. So the idea here is that there are two systems that are dysregulated in heart failure that are targeted by this drug combination. One is the renin-angiotensin system, and activation of that system leads to increased production of angiotensin II, which works on AT1 receptors to cause all of these bad things: vasoconstriction, elevated blood pressure, increased sympathetic tone, increased aldosterone levels, fibrosis, and ventricular hypertrophy. Now, there's another system that's activated in people with heart failure, the natriuretic peptide system, and so that BNP is sort of the classic molecule that we think of in that system. And so the sacubitril portion of that actually is targeting this system, and it actually is trying to prevent the breakdown of these natriuretic peptides by inhibiting an enzyme called neprilysin. So you're trying to increase levels of the natriuretic peptides, which can induce good things: vasodilatation, lower blood pressure, reductions in sympathetic tone and aldosterone levels, and to promote natriuresis diuresis. So I guess a way of thinking about this is that the valsartan prevents all of these bad things by blocking the angiotensin 1 receptor, and the sacubitril promotes all of these good things by increasing levels of the natriuretic peptides like BNP. Oh, by the way, you can't follow BNP levels anymore if they're on this drug, because they're going to be relatively high, because the system that's normally breaking it down is interrupted. You can, though, follow NT-proBNP levels. Okay, so here's the pivotal study that led to approval of this drug combination, the PARADIGM-HF study, which was published a couple of years ago in the New England Journal. They included people with EFs of less than 40% in New York Heart Association classes 2 to 3, and they had to have elevated BNP 150 or greater, or they would accept a BNP above 100 if they'd been hospitalized in the last 12 months. And they had to be on an ACE or ARB at staple doses 4 weeks prior to entry. They were excluded if they had very low EGFR, if their potassiums were above 5.4, or if their blood pressures were relatively low. And the reason for this is the sacubitril does lower blood pressures above and beyond what you'd get. The combination does lower blood pressures about 3 to 4 millimeters of mercury above or more than what you get with the ACE inhibitor alone. People were actually did a run-in to make sure that they could tolerate both either enalapril, or the combination drug, and then they were randomized to enalapril or the combination drug at 200 milligrams twice daily. They enrolled 8,400 patients, so it was a very large heart failure trial. The primary endpoint was a combination of cardiovascular death and heart failure hospitalization, but they actually did power the study to be able to detect a 15% decrease in cardiovascular deaths. And here are the results both for that primary endpoint of cardiovascular death plus heart failure hospitalization or cardiovascular deaths. And in either case, you can see there was a 20% relative reduction in hospitalization plus cardiovascular death or in cardiovascular death. So clear benefit in terms of mortality as well as heart failure hospitalization. So that was a very nice finding and led to approval of the drug. So here are a couple of things, so a few issues if you're going to consider prescribing this for patients. Unfortunately, just in the last couple of months, we've had some guidance from an ACC-AHA Heart Failure Society document that has been published online in May in Journal of the American College of Cardiology. The first key point is that you should not consider this to be a first-line therapy. You can use it for people with class 3 to 4 heart failure who have persistent symptoms on either an ACE inhibitor or ARB. And the level of evidence for the level of indication for that is a class 1, so the highest level indication. But importantly, you do not want to use it in combination with an ACE inhibitor. And if you're switching somebody from an ACE inhibitor to this combination, they have to be off the ACE inhibitor for at least 36 hours before starting this combination. And if somebody has any history of angioedema, you also should not use this, because the molecules that are thought to cause angioedema are increased by this combination. You can use the NT-proBNP assay to monitor, but not BNP levels. It's not safe in pregnancy. And just to kind of give you a relative sense, it turns out that the valsartan in this combination is a different salt than the regular valsartan. So the dosage equivalent is lower. So if somebody's on 160 milligrams a day of valsartan or 80 BID, you would switch them to this higher dose combination of the, or excuse me, if they're on 160 milligrams twice a day, you'd switch them to the 103 milligram valsartan containing dose. These are both dosed twice daily. Okay, the last thing I want to do is talk about this whole issue of drug costs and polypharmacy. And to get an idea of just purely looking at drug costs, I went on my favorite website, Costco.com, where I get all of my most helpful information, to look to see what the different classes cost if you were paying for them out of pocket at Costco. So in terms of diuretics, you can see there's a huge, well, excuse me, in terms of all of these drugs, with the exception of the ARB neprilysin inhibitor, there are low-cost generic alternatives. So furosemide is dirt cheap for 50-day supply at 40 twice a day. An equivalent dose of torsemide, equipotent dose of torsemide costs you about twice as much, but it's still only $22 a day. ACE inhibitors are really cheap, lisinopril. Interestingly, carvedilol is really inexpensive at a dose of 25 milligrams twice daily. That would be equivalent to the 100 milligrams once daily of the metoprolol succinate. Losartan's actually very inexpensive too. It only costs you about $2.50 more a day to be on losartan if somebody wasn't able to tolerate lisinopril. And then interestingly, both of the mineralocorticoid receptor antagonists are generic, but look at the difference in cost with the eplerenone. So that's another good reason why we only use that. Now, on the other hand, the new kid on the block, the neprilysin inhibitor ARB combination, is very expensive. And interestingly, the branded valsartan is also very expensive as well. So you could spend $41 every 50 days if you went with an all generic combination that included the losartan instead of ACE inhibitor. But if you went with all branded medications and used the valsartan sacubitril, it cost you about 35 times as much. And then in terms of generic, if you said, okay, well, we'll use the generics, but we're going to sub out the losartan for the valsartan sacubitril, it costs you about 20 times as much as if you just went with the all generic combination. So you're really in, and now these aren't necessarily what your patients are going to pay because they presumably have insurance, but it costs a lot of money to use branded drugs. And fortunately, all of these key medications and all of these key classes, except the last one, are available as generic. So it's actually very cost effective to treat heart failure nowadays. So to finish up with going back to the questions. So question one, the 59-year-old man who had an MI, stented his LAD, came back to clinic with a creatinine of 1.3, clopidogrel, simvastatin, and long-acting metoprolol. Which drug is most likely to reduce his long-term mortality? So we'll go back to the poll. Okay, there you go. You go ahead.
Okay.
Yes, ACE inhibitor. Great. Okay. So then the next one, oh yeah, that's definitely ramipril. So the next one, and I'm sorry. He's already on a beta blocker, which would reduce his mortality. But we know that ACE inhibitors of the other three drugs, ACE inhibitor is the one that would dramatically also reduce mortality by about 30 to 35%. Diltiazem is not indicated in people with heart failure. Omega-3 fatty acids, there was a suggestion in an Italian study that maybe they would be helpful, but when that study was repeated, it was found that they were not useful. And then warfarin has not been shown to improve mortality, and in general, we don't use warfarin in patients anymore with heart failure unless they have another important indication, for example, atrial fibrillation. Okay, Question 2, a 65-year-old man follows up in your clinic after a heart attack. And he also got a stent because we're very good at doing that as cardiologists. Sent home with dual antiplatelet therapy and atorvastatin. So he goes back to your office, blood pressure a little bit on the low side, 94 systolic. Which would be the first medication you'd initiate? Polls open.
All right.
Okay.
There we got our 5th.
Okay. Great. So yes, it would be the lisinopril. And again, the point here is that we need to get somebody on some vasodilator before starting the beta blocker. If somebody has decompensated heart failure or marginally compensated heart failure, we do run the risk early on of causing a decompensation if we add the beta blocker, because it is going to acutely lower inhibits systolic function. It has a negative inotropic effect. So it's just keeping in mind this idea that either the metoprolol XR or the cardiovascular are very helpful in decreasing mortality, but their benefit is long-term. So we need to get people decongested with diuretics and on some vasodilator, and then start beta blocker at a low dose. So yes, and warfarin was still not good. So, and then question 3, here's the 73-year-old. He's already on aspirin. He's on a ACE inhibitor, beta blocker, and his antistatin. His creatinine is 1.6, and so because of his age, his estimated GFR calculates out to stage 3 chronic kidney disease. So you discuss the case with a medical student, explain increasing the statin dose is the way to go. Start him on a low dose of spironolactone, start on the typical starting dose of spironolactone, or say that because of his age, spironolactone is not indicated. Polls open. People have already jumped on.
That 5th one.
Fifth person? Yay, all right. All right.
100%.
Give yourselves a hand.
All right.
That's great. Right. You know, it's not so. Statins actually in randomized trials have not been shown to affect mortality in people with heart failure. Turns out, and that but because of this patient's reduced renal function, we should just be safe and start him on the reduced dose of 12.5. And actually, you know, the average dose in RALs was only 27 milligrams a day. So taking all comers, you can have a dramatic effect on mortality with modest low doses of that medication, which is good.
Great.
All right. I did want to just kind of what?
We're very much out of time.
Oh yeah. Well, I'll make this quick. So what we're trying to do with the polypharmacy here is we're treating people in their early stage of heart failure when they first present. We understand that people are going to have a lot of heart failure hospitalization, continue to have risk for heart failure associated and non-heart failure associated admissions. But when the tempo of heart failure hospitalization starts to increase again, they're really in this plateau or in this palliative phase where they need advanced heart failure consideration, and that could be consideration for transplant, LVAD, or in many patients, they're not candidates for those therapies, and so we need to consider palliative care. So I threw this in as a lead-in.